Hello everyone, my name is Patricia Clarine Simpson with the last 3 digits number 125. We are from SGD B4 and right now we are going to present our student project titled Pneumoconiosis. So here's the list of our members in small group discussion B4.
Thank you so much for the opportunity. First of all, let me introduce myself. My name is Rahel with the 3 last digits of my student ID 030. So in this video, I'm going to explain about our background of this student project. So we know that industrialization frequently generates dust or other foreign particles that could potentially harm the workers. And based on the data from the World Health Organizations, there are 1.1 million deaths globally related to this occupational disorder, and 5% of it is a pneumoconiosis. Pneumoconiosis is a lung illness that induced by inhalations of the organic or inorganic airborne particles that typically encounter these inhalations during the job. And in these recent years, pneumoconiosis is common and poses a severe threat to worldwide public health due to inadequate workplace protections, as well as the lack of early diagnostic procedures and appropriate therapies. So in this student project, we will delving deeper into these explanations so we can build up the public awareness, particularly among the healthcare professionals, policymakers, and the general public health awareness regarding this pneumoconiosis. That's all for me. Thank you.
My name is Jacinda Isadora Mannuela Simanjuntak with last 3 digits of my student number 147. In this paper, the problem formulation that we will discuss is as follows. What is the prevalence and epidemiology of pneumoconiosis? What are the etiology and risk factors for pneumoconiosis? What is the pathophysiology of pneumoconiosis? What are the clinical manifestations and diagnosis of pneumoconiosis? What are the clinical symptoms of pneumoconiosis? What are the diagnostic techniques for pneumoconiosis? What is the differential diagnosis of pneumoconiosis? What are the treatment approaches for pneumoconiosis? And what is the prognosis of pneumoconiosis? The general objective of this paper is to learn more and further about pneumoconiosis, and the specific objective that could be formulated are to answer the problem formulation that we discussed. The benefits of this paper for the authors and the readers are to enhance knowledge about pneumoconiosis and provides deeper understanding about it.
Okay, so let me introduce myself first. My name is Anjanika Surawi with 3 last digit name number 164. I will continue on the prevalence and epidemiology of pneumoconiosis. So according to the Global Burden of Disease Studies, prevalence of pneumoconiosis has been declining since 2015. There were approximately 500 to 27,500 cases worldwide, with more than 60,000 new cases reported that year. Notably, pneumoconiosis has appeared in countries like the United States and Australia. In less developed countries with poor reporting mechanism, it is likely that many cases go undiagnosed and unreported, making it challenging to accurately estimate the true prevalence of the disease. Additionally, because pneumoconiosis diagnosis can result in job loss, many workers may avoid seeking medical examinations even when they exhibit symptoms, leading to delayed detection.
I will continue the presentations, but before that, my name is Ayu Prewerti Nia Surya with last 3 digits student number 230. Now I will explain about the etiology and risk factors of pneumoconiosis. Pneumoconiosis is caused by the build-up of small inhaled particles such as inhaling dust, talc, silica, asbestos, fibres, and beryllium, which triggers an inflammatory reaction within the lung. The risk factors of this disease is first, male. Men, being physically stronger during labor, they will experience faster lung ventilations that leading to a higher occupational dust inhalation. Gender differences in genotype expressions and higher smoking rates among men contribute to a greater incidence of pneumoconiosis in men. The second one is co-workers occupational category. Varying morbidity may be primarily caused by differences in dust concentrations at work, along with factors like lifestyles, work habits, and working hours across different vocational groups. The third one is durations of dust exposure. Pneumoconiosis progresses through fibrotic, inflammatory, and anti-inflammatory process, with gradual advancement due to a constant dust exposure, highlighting the need to reduce work time in high dust environments or adjust shifts for employees with increasing morbidity. The next one is cumulative total dust. Current research identifies dust as the primary occupational risk factors for pneumoconiosis, with higher dust concentrations potentially increasing the risk of developing the disease. The last one is smoking. Smoking increases the risk of pneumoconiosis and worsens overall mortality, with studies focusing on the disease morbidity and mortality. It damages the bronchociliated epithelium, limiting dust removal from the lungs, while toxic chemicals can alter genes expressions and harms affected organs. That's all from me. My friends will continue. Thank you.
Well, thank you for the opportunity. First of all, my name is Putri Balkis Hansal Khansa with the last three digits number 136. Right now, I'm going to explain about the pathophysiology of pneumoconiosis. Pneumoconiosis is primarily caused by pathophysiological mechanisms including inflammations and fibrosis. Dust accumulation in the lungs sets off an immunological reactions and activates inflammatory cells, which release a variety of chemicals, such as adhesion molecules, chemokines, and cytokines. Other immunological inflammatory cells, such as T and B lymphocytes, have also been linked to advancement of pneumoconiosis in addition to macrophages. All of these mediators cause chronic inflammation in lung tissues and encourage fibrosis.
Okay, thank you for your time. But first, allow me to introduce myself. My name is Wulan Ekaputra Tanuwidjaja, with the last two digits of my student number being 084. I'll be continuing the presentation by explaining the key clinical symptoms of pneumoconiosis, which is a lung disease caused by inhaling dust particles. The common symptoms would include persistent cough, usually with a black sputum, and shortness of breath that worsens over time, chest tightness, and increased sputum production. Specific symptoms may vary based on the type. For example, the first one is cold worker pneumoconiosis, or CWP, which can produce black sputum, which can be mild in the early stages, but in advanced forms, it can lead to severe breath difficulties and lung damage. Asbestosis can cause progressive shortness of breath, dry cough, and chest pain, while silicosis increases the risk of tuberculosis in general. Bucinosis from cotton dust exposure causes chest tightness and breathing issues, especially early in the work week. As these diseases progress, complications such as respiratory failure, lung cancer, which is particular, especially in asbestos, and heart failure can also occur. That's it for the key clinical symptoms. I'll let my friend here continue. Thank you.
Thank you for the opportunity. My name is Niputulan Prasanti with the last three digit NIM number 138, and today I would like to discuss about the diagnostic techniques of pneumoconiosis. So pneumoconiosis is diagnosed based on three main criteria: long-term exposure to inhaled cytotoxic dust, radiological evidence of pulmonary fibrosis, and the absence of other diseases that could suggest alternative diagnosis. Since the symptoms of pneumoconiosis are non-specific, a detailed history taking is important, particularly focusing on occupational exposure to dust such as coal, silica, or asbestos, how long they've been exposed, as well as habits such as the use of personal protective equipment and smoking habits. Symptoms commonly include dyspnea and persistent cough that develop gradually. In co-worker pneumoconiosis, black pigmented sputum may be observed. On physical examination, tachypnea and inspiratory crackles may be found. Pulmonary function tests typically reveal a classic restrictive pattern. Imaging play a key role in diagnosis, starting with a chest X-ray, which may show extensive opacities primarily in the upper zones of both lungs. In asbestosis, chest X-ray reveals small, irregular opacities with a reticular linear pattern with plaques or thickening of the pleura. In silicosis, small rounded opacities can be found in the upper and mid zones of the lungs, with characteristic eggshell calcification of the hilar lymph nodes. The radiological findings in co-worker pneumoconiosis are similar to silicosis, but the nodule may appear less defined and more granular. For more detailed evaluation, a CT scan may be performed. In case where there is suspicion of progressive massive fibrosis or lung cancer, MRI can help differentiate between the two. In rare cases, if imaging and clinical history do not provide a clear diagnosis, a lung biopsy may be considered, but that's not usually necessary.
Hello, my name is Bernard with the last digit of my student number is 103, and right now I will discuss the differential diagnosis of pneumoconiosis. The first is hypersensitivity pneumonitis. Both HP and pneumoconiosis are caused by inhaling harmful substances and share symptoms like coughing and shortness of breath. However, the trigger in HP is mold spores and allergen, whereas pneumoconiosis results from cytotoxic dust particles. Next is idiopathic pulmonary fibrosis. Both condition leads to lung scarring and present symptoms like coughing and breathlessness. The difference lies in their cause. Pneumoconiosis is due to dust inhalation, while IPF has no clear cause. The third is tuberculosis or TB. Both TB and pneumoconiosis can cause severe lung damage with persistent cough and shortness of breath. The key difference is TB is an infection disease caused by Mycobacterium tuberculosis, while pneumoconiosis is due to inhaling inorganic dust. Next is chronic obstructive pulmonary disease or COPD. Both COPD and pneumoconiosis lead to impaired airflow and symptoms like chronic cough, but however, pneumoconiosis stems from inhaling inorganic dust, while COPD is often linked to smoking and other environmental pollutants. Finally, there's lung cancer. Both lung cancer and pneumoconiosis result from prolonged exposure to harmful chemicals, causing breathlessness and a persistent cough. But the root cause is diverse. Lung cancer is due to genetic mutation in lung cells, while pneumoconiosis causes physical damage to lung tissue through dust inhalation. In summary, while pneumoconiosis shares symptoms with many lung disease, understanding their distinct causes is key to making an accurate diagnosis. That's all from me. Thank you for watching.
Hello everyone, my name is Sashikirana with Charel student number 087, and now I will explain about the treatment approaches of pneumoconiosis. Currently, there is no specific treatment for pneumoconiosis and only limited to symptomatic therapy. People with pneumoconiosis have a high risk of respiratory morbidity and mortality. Therefore, treatment aims is to relieve symptoms, delay disease progression, and enhance a patient's quality of life. Patients with pneumoconiosis should avoid any additional contact with the causative inhalant substance. Preventive strategies include wearing masks or avoiding polluted settings. Smokers are also recommended to quit. In certain cases, the therapy for pneumoconiosis includes pulmonary rehabilitation to support patients in maintaining an active lifestyle. Breathing exercise, endurance and strength training, education, and psychosocial support are common features of these rehabilitation programs. In more severe situations, a lung transplant may be considered. Okay, I think that's all from me. Thank you.
I am Wulan Triyanti with true last digit number 86 and I will deliver 2.7 prognosis. Pneumoconiosis progress through 3 distinct stages: Stage 1 representing the mildest form, Stage 2 as an intermediate stage, and Stage 3 as the most severe, including classification B and C. As the disease advanced from Stage 1 to Stage 3, mortality rates increased significantly, largely due to the severe decline in the lung function seen in the later stages. Life expectancy also decreased as the disease worsens, but preventive measurements and strategies to limit its progressions can greatly enhance patients' survival. On average, patients diagnosed with pneumoconiosis may live for about 14 years, although this figure varies depending on the patient's age at the diagnosis and the severity of the disease. Early diagnosis, particularly in Stage 1, is associated with a much better prognosis compared to those diagnosed in the later stages. where mortality risk rise sharply. Additionally, chronic exposure to occupational dust plays a critical role in reducing life expectancy as it exacerbates lungs damage over time. Once the disease reaches its fibrotic phase in the advanced stage, lung damage becomes irreversible, making the prognosis much worse. Therefore, early detections and preventions are crucial in improving outcome for patients with pneumoconiosis. Thank you.
Greetings, my name is Aryanda Maitri Anjasrini with the 3 last digit of student ID number 188, and here I'll be explaining about the conclusions of this paper. So, pneumoconiosis is a lung illness induced by the inhalations of organic or inorganic airborne particles, such as dust and fibers. These particles promote inflammations and fibrosis in the lung, leading to permanent lung damage. Global burden of disease study shows a significant number of pneumoconiosis cases worldwide, with high mortality rates and over 21,000 deaths annually since 2015. Pneumoconiosis is primarily caused by inhaling dust particles like silica, asbestos, and beryllium, leading to fibrotic lung disease. Risk factors for pneumoconiosis include male gender, smoking, co-worker occupational categories, durations of dust exposure, and cumulative total dust. The disease presents with symptoms like persistent cough, shortness of breath, chest tightness, and increased sputum production. Differential diagnosis includes disease like hypersensitivity pneumocystis, idiopathic pulmonary fibrosis, tuberculosis, COPD, and lung cancer. Currently, there is no specific treatment for pneumoconiosis and only limited to symptomatic therapy that aims to relieve symptoms, delay disease progressions, and enhance a patient's quality of life. That's all from me. Thank you.
So that is all for our presentation on pneumoconiosis. We hope that this video was useful and informative, and thank you for listening. Have a good day.